So I'm going to go ahead and get started. Just as way of introduction again, I'm Jennifer Wo, and I am one of the GI radiation oncologists at Mass General. I've been on staff for over a decade there. And today I'm going to be talking about proton therapy for gastrointestinal cancers. My specialty, is it better outcomes or is it just more costly? And I think, you know, where certainly in the United States, there's been a lot of concern about increasing healthcare expenditures. This is an area that the NCI is particularly focusing on to, for radiation oncologists to generate proof that, in fact, proton radiotherapy has a role. So these are my conflicts of interests to disclose. So I'm sure as many of you are aware, proton radiotherapy has a lot of appeal. It's a particle with charge and mass. There's a defined range in tissue which is proportional to the energy. And for an unmodulated proton beam, there's a dose deposition and a sharp Bragg peak beyond which there's no dose delivered. And you can modulate the beam such that there is a spread out Bragg peak towards the surface to treat tumors. And you can see the red is the Bragg peak beyond which there is no dose deposition, and that's in contrast to photon-based radiation, where there is continued dose deposition beyond the target in the tissue, and therefore increase unwanted dose to normal tissues. So there are multiple rationale for potential clinical benefit for proton radiotherapy by narrowing that therapeutic index, and I'm going to break it down to three main potential benefits. One is by decreasing dose to normal organs at risk. It may decrease acute and late toxicity and thereby impact quality of life for our long-term survivors, as well as overall survival if that quality of life is impacted significantly enough. Additionally, it may allow for dose escalation and thereby improving local control, and if local control yields to improved outcomes and overall survival, that's another real benefit. And then in the setting of immune surveillance, where we know that immunotherapies have more and more of a role in our tumor types, could it potentially lead to improvement in treatment-related lymphopenia? Does that then yield improved immune surveillance and thereby yield improved outcomes? So these are three different mechanisms that we're going to talk about when we think about protons for GI cancers. So this is the overview of my talk today. I'm really going to focus where I think there's a bulk of data, and that's there are two ongoing phase 3 randomized trials in the United States up and running right now. One is for hepatocellular cancer, one is for esophageal cancer. So I'll focus the predominant area of my talk on these two sites. I'm going to touch briefly on anal cancer, where there's also been prospective data. And then really outside of the scope of today's talk, which there's certainly case reports and retrospective series or some dose symmetric data that shows possibility of benefit, but outside of the scope today is pancreatic cancer, rectal cancer, and reirradiation, which obviously there is significant rationale for doing. So moving forward, protons for hepatocellular cancer. For those of you who don't routinely treat HCC, the majority of the patients with HCC actually present with locally advanced unresectable disease due to tumor extension and invasion into major vasculature, like portal vein tumor thrombus. For patients that are not suitable for curative modalities, which include transplantation, resection, or ablation, local regional therapies and systemic therapies often are what we go to and are available. The issue with HCC is that you're really treating two specific diseases. One is the cancer itself, and one is the underlying cirrhosis that sort of predisposes it. And so it's a very, it's like threading a needle to figure out the right therapeutic option to optimize tumor control but minimize damage to the underlying liver. We know in our liver-directed toolboxes, we have multiple therapies that we have now in our armamentarium. Obviously, ablation, radiofrequency or microwave ablation has the most sort of long-standing history, and then subsequently embolization or chemoembolization. And then more recently, I would say over the last decade plus, we have liver SBRT that's really emerged as a very viable option, as well as Y90 or SIRT. Now, historically, liver radiation has been really dampened the enthusiasm by early 1960s paper that showed that when you treat the entire liver, there is significant concern for toxicity with patients developing hyperemia and fibrin deposition, with most resolved findings after 4 months. And what we've learned from looking at the surgical data is that you can do partial hepatectomies on up to 75% of the liver, and the 25% will regenerate that's remaining. And so therefore, using radiation as a similar modality where you're ablating portions of the liver, we know is now more and more feasible. When you treat the whole liver, you have dose tolerances around the 30 gray range. But when you're treating only a third of the liver, this is the whole liver and this is a third, you can treat much higher doses that are easily ablative. And once again, there may be differential in terms of tolerance based off of the underlying liver functionality. But if you have primary liver, you can take it easily up to 90 gray. And if you have liver metastases and otherwise healthy, you can certainly go much higher than that. So as, once again, many of you are aware, there's a lot of recent technological advances that have allowed for liver SBRT to take hold and gain a lot of traction. We're better at target delineation with MRI fusion now with 3D CT planning systems. There's also now MRI-based Linux that I'm sure a lot of the talks today are going to talk about. In addition, we have improved motion management strategies, so 4D CT planning, which we routinely do for all of our liver patients. There's ways to control respiratory motion with active breathing control or abdominal compression or respiratory gating, which we do in many of the patients that have more significant breathing. Additionally, there are other tools that we can utilize to track patients better. So we do often use liver fiducial placements pre-treatment and line up to fiducials. And then we do daily pre-treatment cone beam CTs for all of our SBRT patients. And then just at baseline, radiation treatment planning and delivery systems are much more sophisticated than they were a decade or 2 decades ago. So if you look at, this is a summary of some of the prospective data that has existed for liver photon-based radiation. You can see that the local controls are quite favorable depending on which series you look at and the size, the median size of the lesions, but many of the reports are upwards of 85 to 90+% in terms of local control, really highlighting the efficacy of this approach. However, the overarching balance that we always have to weigh is the potential for GI toxicity and particular liver decompensation rates. And so, I think a lot of the toxicity is based off of proximity to luminal organs, so you're looking at GI ulceration or perforation. And then when we talk about ascites, thrombocytopenia, hyperbilirubinemia, that's when we're really talking about liver decompensation rates. A lot of it is also going to be dependent on the underlying Child-Pugh status of the patient at baseline that can dictate this as well. So patient selection is critical. So just moving on to proton-based radiation. So this is one of the earlier patients that we had done, and this is a 4-field plan. A lot of the planning we had traditionally done has been passive scatter with 3D planning. This is the same patient with a 5-field plan. And you can see, just like any 3D plan, beam arrangement is critical in terms of determination of dose to the normal liver and to the other structures. But proton certainly allows for very sharp dose fall-off that preserves a good chunk of the liver, which would otherwise be bathed in a low dose to the liver. So this is one of my patients that I treated 5805 in 15 fractions. And once again, you can see really complete sparing of that left lobe of the liver. So there actually has been, quite a significant history of proton-based data that's been published, both retrospective and prospective. This is one of the earlier data sets that was published out of Japan, 162 patients. You can see variable size with 72 gray, with the median fraction size at 4.5 and a 5-year local control, once again around the same, about 87%, which really sort of was proof of concept that this is a very viable option. And then since then, there's been a whole bevy of prospective data that has emerged. There's data from California and the United States. Loma Linda and MGH were the 2 first sites of proton-based radiation. And we've done a lot of work moving this concept forward. And you can see this is a summary of the dose fractionation schemas that have been used, mostly 10 to 15 fractions. I think that's been published out there. And you can see nicely the local control rates on that last column, highlighting once again, 85+% control. So this is, I'm just going to go into a little bit more detail. This is the MGH UPenn and MD Anderson series that was published in JCO in 2016. This was a multi-center phase 2 study, and we used 15 fractions, 67.5 gray in the periphery, and then 58.05 and 15 fractions within 2 centimeters of the porta hepatis. And you can see we treated both hepatocellular cancers as well as intrahepatic cholangiomas, and I think really this set the groundwork for intrahepatic cholangiomas as well as a retrospective series published in MD Anderson at the same time, that this is a viable option for that population as well. These were generally larger tumors, and you can see the far majority of patients received 5805. And only 4% of patients had grade 3+ related toxicity. 1 patient with a stomach ulcer, 1 patient had liver failure and ascites, and there was no grade 4 radiation-related toxicities. So excellent local control for both the liver cancer and intrahepatic cholangio population, and all patients who had progression had less than 60 cobalt gray equivalents. When we looked at 2-year progression-free survival, you could see that progression-free survival and overall survival were generally worse for intrahepatic cholangiomas. Not surprising that population has a higher likelihood of having distant failure than HCC. And so I think the conclusion of this study was that it certainly is associated with high rates of local control, it's safe, and long-term survival is possible, and in HCC even expected. This is a nice series, a randomized study of TACE versus proton beam radiation. I think that's where a lot of the more recent studies have been going in terms of randomization. I can tell you that he has recently been working to update this series because this was interim results, 70.2 gray and 15 fractions versus TACE with progression-free survival as a primary endpoint. And what was really notable about this, it just met just shy of statistical significance, but you can see there is a clear difference in terms of local control with protons. You can't see it because the color is not longer there, but the protons actually did much better than TACE as well as progression-free survival. They actually also looked at hospitalization rates or time in the hospital, cost, expenditures, and it favored protons on all metrics. And then even more recently, this is a randomized trial that came out of Korea of protons versus radiofrequency ablation of 144 patients treated at the National Cancer Center, randomized to receive protons or RFA, and they used 66 cobalt gray equivalent in 10 fractions. And it was designed as a non-inferiority trial with a 2-year local progression-free survival rate as the primary endpoint. And you can see at the primary endpoint, if you look at intent to treat, it was statistically significant with a 2-year local compression-free survival rate of 93% versus 83%. And then also really notable is if you look at toxicity, it actually had improved, associated with improved, statistically significantly improved grade 3+ toxicity, as well as change in Child's Pugh score favoring the proton radiotherapy. So I think this all sort of incrementally supports that proton radiotherapy really is very well tolerated with excellent local control. So I think, you know, as we talked about, it's a double-edged sword when you're treating HCC. Is survival in this patient population driven by local control, or is it driven by hepatic toxicity? So Princess Margaret, this is a, you know, Laura Dawson is like the godmother of a lot of HCC work in the Western Hemisphere. And this is her series that she published, her phase 2 publication in JCO. And, you know, this was with photon-based radiation versus the MGH UPenn MD Anderson series, which is proton-based radiation. You can see that the local control in both series were quite excellent, but what is very different between the two series is actually the worsening of Child's Pugh score at 3 months. You're looking at 29% with photon-based radiation versus 3% with the proton-based series. So that led to our question, well, really, are protons better than photons? So we retrospectively reviewed 133 patients treated at MGH, looking at 84 treated with photons and 49 patients treated with protons. And not surprisingly, there was no difference in local failure rates. So either you're going to get great local control. But there was significant improved survival with proton-based radiation, which is 31 months versus 14 months, despite the fact that there was no local control benefit. And when we delve into why, it really is because it was less likely to be associated with liver decompensation post-radiation. And this is a scatter plot of dosing of mean liver minus GTV dose. I mean, the solid was greater than 21.6, and the empty was less than 21.6. And you can see certainly a higher dose to the mean liver minus GTV dose was associated with higher likelihood of developing liver decompensation. And what we found on a dosimetric analysis was that the remnant volume of liver receiving 10 gray or less was better with protons. And we did identify this as a factor. And once again, on multivariate analysis, proton radiotherapy remains significant, or remains significant in terms of overall survival, but not different in local failure. And then this is a really nice series that was recently published out of with Dr. Chang here, looking at a propensity scored matched analysis of proton versus protons. Ultimately, 55 patients were matched on multiple different factors, including age, sex, histology, underlying liver fibrosis score, tumor size. And what you can see is that protons led to a higher BED and a lower rate of RILD. And this is the dosing schema that they used. And the median survival was not reached with protons versus photon-based treatment, which is 17.4 months. And this was statistically significant. And so as I mentioned, is there real differences? Well, I think shy of a randomized trial, we don't really know, but there's certainly a lot of hints that there is. I can tell you there's a lot of debate. Could it be patient selection between different, series? If you look at the Toronto series versus the MGH and MD Anderson series, patient selection, fractionation differences, modality difference. And the only way to really determine that is a randomized trial. And so this study has been ongoing, up and running over the US. I can tell you it's predominantly led by MGH and MD Anderson. And the target accrual is 167 patients. And I think we're just about halfway there to accrual at this point in time. We are liberal in our the way that patients are prescribed. It's either 5 or 15 fractions. And this is the mean dose that we accept for the different fractionation schemes used. And then the next question is, are there ways to better select for patients that would benefit for one versus the other? And there's some early data from MGH that suggests that perhaps there is, if you can find patients with lower pretreatment plasma hepatic growth factor. It was associated with no increase in Child-Pugh score. And so, potentially there are biomarkers of toxicity. So, we have ongoing HCC studies in which we're trying to collect all of this so that we can retroactively do this kind of analysis. And when we found that increase in Child-Pugh score and pretreatment plasma hepatic growth factors were associated with survival. So I think that's sort of a summary of where we are for HCC, and hopefully in the next, I would say, few years, it'll probably take another 2 years or so for the trial to complete accrual, we'll have an answer to this question. I'm going to shift gears now to esophageal cancer, and a lot of the data here has actually come from Dr. Steve Lin, who is the president of TARS this year. So I'm going to be quoting a lot of his work from MD Anderson. But certainly within the United States, there is an increasing incident more than many other cancers of adenocarcinomas among white men. It's certainly one of the fastest growing populations of patients that we see. And then, there's really well-established data in the setting of both the neoadjuvant setting and the definitive setting for chemoradiation for esophageal cancer. This is the cross data that was published out of the Dutch, out of the Netherlands, showing a median overall survival benefit with chemorads versus surgery alone, with a 5-year overall survival of 47 versus 34%. And then more recently, this is the Art Deco study, which was a study of looking at high dose versus standard dose, showing no benefit of dose escalation for esophageal cancers, either in terms of overall survival or progression-free survival. But what you can see is that as you dose escalate, it certainly is associated with significant increase in grade 4 and grade 5 toxicity. So Steve Lin has done a lot of work looking at esophageal cancer and the role of proton radiotherapy. And you can see this is 3D on top versus IMRT versus proton beam radiotherapy. And what you can see is that the dose to anterior structures, i.e. the heart, the lung, are much higher with 3D and IMRT than they are with proton beam radiotherapy. And so a lot of work has been done off of here, both dosimetrically. You can see, not surprisingly, that if you do dosimetric comparative analyses, you can see much lower doses to sort of all metrics of the lung and the heart, as well as the kidney. This is just a patient that I treated with pencil beam scanning in our population. And once again, you can see really nice sparing anteriorly with a single PA beam. And so when, other than just improved dosimetric pictures, like are there actually clinical benefit? Well, protons may improve outcomes by improving postoperative pulmonary complications. This is a series that was published in the Red Journal quite a while ago in 2013, comparing patients that were treated with 3D versus IMRT versus proton beam radiotherapy. And what they found at MD Anderson is that if you looked at 3D versus IMRT, it significantly decreased pulmonary complications and GI complications, as well as if you compare 3D versus proton beam radiotherapy. So once again, you can see the bar chart to the right, significant rates, improvement in rates of those complications. And that mean lung dose was really found to be the main predictor of post-op respiratory complications that we saw in this patient population. A subsequent study was a multi-institutional study of here and MD Anderson and Mayo and others that were over 600 patients, once again confirming that improved pulmonary complication rates, cardiac complications, wound complications, and then more meaningfully in terms of healthcare expenditures, length of hospital stay when we looked at proton versus other modalities. I'm going to briefly touch about immune surveillance, which I brought up at the very beginning. I think there's a whole lot more data now, more and more, looking at the interplay of radiation and immune surveillance, and a lot of data leading into this work looking at lymphopenia. We always thought radiation has a local regional effect, but we know that it can also positively and negatively impact the immune system. This is some early work from Susan Jovina that looked at sort of fractionated radiation for GBM patients, and you can see over the course of a 30-fraction treatment, almost 99% of patients end up having a single radiation dose greater than 0.05, which is the dose necessary to cause lymphopenia. And since that time, there's a lot more data looking at correlating same outcomes of grade 4 lymphopenia with outcomes in pretty much all cancers, cervical cancer, pancreatic, anal, GBM, across the board. We know that radiation reduces, grade 4 lymphopenia can meaningfully impact outcome. And then even more convincing now is now in the era of Checkmate 577 that adjuvant nivolumab has now been accepted as standard of care for patients with residual disease after neoadjuvant chemoradiation, where we know IO is important for improvement of disease-free survival. That sort of highlights, yet again, that importance of that immune surveillance that we talk about, especially for esophageal cancer. And this is nice work, once again, by Steve Lin that showed that grade 4 lymphopenia retrospectively was associated with worse outcomes across the board: overall survival, disease-specific survival, local regional free survival, and distant met-free survival. And when they looked at what specifically was correlated, they could see that the grade 4 nadir was associated with higher mean body dose, so 12.7 versus 10.8 gray. And if for a mean body dose of less than 10 gray, it was grade 4 lymphopenia was 16.8% versus 33%, and higher if mean body dose was greater than 10 gray. And when you account for that impact on mean body dose, proton beam radiotherapy fell out of the model for overall survival. So based off of all this retrospective work, MD Anderson launched a randomized phase 2B trial of proton beam radiation versus IMRT, and this was published in the JCO in 2020. They randomized 145 patients to IMRT versus proton beam. Ultimately, 107 patients were evaluable, and they did a co-primary study endpoint of total toxicity burden, which was a composite score of 11 distinct adverse effects and postoperative complications, as well as progression-free survival. And they did a Bayesian group sequential design with the 3 planned interim analyses. And this ultimate study was closed early because of the launch of the randomized study that I'm going to talk about in just a little bit. So this was the one of the co-primary study endpoints. This is the posterior mean total toxicity burden, and it was found to be 2.3 times higher for IMRT versus proton beam therapy, 39.9 versus 17.4, and this was statistically significant. And there was, among the surgical population, a much higher mean postoperative complication score for IMRT. So all of this sort of, again, supports this idea of improved post-op complication rates. The most pronounced differences when they look specifically at the post-op complications were atrial fibrillation, asymptomatic pleural effusions, ARDS, reintubation, and low-grade radiation pneumonitis. Interestingly enough, when they looked at quality of life, there was no difference in quality of life metrics among patients that were surveyed. And there was less grade 4 lymphopenia that was appreciated with proton beam radiotherapy. However, at time of reporting, there was no difference in overall survival or progression-free survival. So the other study co-primary endpoint was not met. So this study is also currently ongoing right now. This is the NRG GI006 study, which is for which Steve Lin is the PI of the study, randomizing between photons versus protons. They allow for adenocarcinoma or squames. And then, it's stratified by induction chemotherapy, candidate for post-chemoradiation resection, and stage of the patient. And so hopefully we'll hear about that study reporting out in the probably next few years as well. Lastly, I'm going to touch just briefly upon protons for anal cancer, because there has been prospective data in this space as well. And as many of you know, anal cancer is treated with definitive chemoradiation. It's very effective. It's a story success for organ preservation and offers very high rates of cure. But as many of you know, it's associated with significant treatment-related toxicities, both acute and late toxicity. And so this is just a summary of some of the late sequelae that many of you experience in treating anal cancer patients. And you can see this is ultimately how, with long-term survivors, but a lot of significant morbidity that's associated with treatment, this is a real, that was the understanding of potential benefit for proton radiotherapy in this setting. So RTOG 0529 set the stage with a phase 2 study of dose-painted IMRT. And it was a smaller series, but of prospective data looking and showing that there was improved GI and 3+ GI toxicity with IMRT. And it is now considered standard of care in the United States in conjunction with concurrent 5-FU mitomycin. And a lot of the early work looking at protons, of course, dosimetric data showing significantly reduced doses to normal tissue structures, especially the low-dose bath when we look at small bowel, external genitalia, femoral heads, and bladder. But there was no significant differences seen in the higher dose range, once again, because of the close proximity of the CTV to these organs at risk to get coverage. So we performed a feasibility study, a prospective study between here, or MGH and UPenn. And we had a target accrual of 25 patients. We used this exact same dosing strategy as RTOG 0529. And we did with concurrent 5-FU and mitomycin at day 1 and day 29. And then we assessed toxicity during and then post-treatment. This is just a sample patient that was treated on study where you had a single PA field to treat the mesorectum and the primary tumor, and then you had a AP field to treat the inguinal elective nodal field. So ultimately, we had 23 of 25 patients who completed the proton beam therapy as planned. 2 patients ended up dying on treatment. 1 that was related to grade 5 related toxicity, which was due to the multi-organ failure due to sepsis, and then 1 patient that had a cardiac arrest, which was felt to be unrelated. And then there was a median dose break of 0 days, median treatment duration of 42 days. And this is our treatment toxicity, as I mentioned, which was our primary endpoint of the study. We did have stopping rules, but we did not quite meet it. Most of the toxicity was actually hematologic, which is not surprising in the setting of mitomycin C, which we know can cause significant toxicity. And our outcomes were generally sort of equivalent to what's been published out there, 88% with a clinical complete response, a 2-year local failure of 12%, and an 84% 2-year overall survival. However, when we compared across modalities, when you look at our reported data versus 0529 versus 9811, we found that the overall grade 3 plus toxicity was pretty much equivalent. But when you looked at specifically GI, it actually was not much better. Ooh, I'm sorry. It was not much better. It was 36 versus 36%, which is in 9811, so equivalent to what was published in 3D conformal radiation therapy, but with IMRT being able to scalp so nicely along the bowel, we didn't really see much of a benefit there. But hard to know. There were other comorbidities that, we initially excluded patients with inflammatory bowel disease, but because patients had inflammatory bowel disease, it actually prompted more of a desire for them to be placed on protons. So there's, 1 patient had prior TBI, so it's hard to know 100%, but I think in general, we did not move this concept forward because of, the lack of significant benefit that we saw. There are additional studies that are underway for anal cancer, but I would say there are certainly challenges occurring to these studies, mostly because of insurance coverage in the United States. They're very selective, and IMRT does so well that I think there's dying enthusiasm at large for this patient population. I'm going to end by just highlighting some of the technical challenges that we've had for proton radiotherapy. I would say that some of my patients, especially the ones on the randomized trial, I'm not always actually hoping for protons. A lot of times I'm actually mentally hoping that they get randomized to photon radiation despite all the data that I've shown. And that's because there are some real challenges, I think, real benefits and real challenges. There's range uncertainty that can be an issue, especially if you have patients that you're not quite sure about. On setup uncertainty, and this is very, significant variability in bowel, gas, bladder filling. If you're treating in the pelvis, variability in acidic fluid. This can be a huge issue for patients if you have HCC with underlying, child's puberty patients that have variable ascites buildup requiring TAPS. There's weight loss over the course of treatment. And to address this, you would do larger planning margins. You can do compensator smearing or utilization of several beams to sort of mitigate that. Additionally, really well and gaining traction, this understanding of uncertainty at the end of range. Is there potentially a higher LET or RBE at the end of range? And this has been published most notably in like the pediatric population, where you're seeing, previously had done a single PA beam, and then you're ranging out along areas that you want to avoid and spare, i.e. The brainstem, but what they actually found was higher rates than anticipated of necrosis along the brainstem. Similarly, we've definitely, we would not want to range out on a luminal structure like a stomach or bowel, because certainly at risk for, if you're doing a higher dose per day, perforations. And I would say I've had 1 gastric perforation over my career for HCC, and it was for proton radiotherapy, where it did range out, but it was unappreciated at the time. Additionally, when you're treating the liver and the esophagus, you have motion management strategies. You have free breathing in many of the patients, or in the esophagus, you can have peristalsis. So you have to do 4D dose calculations, tumor tracking and gating with external surrogates or fiducials. You need a motion robust planning system, and we oftentimes do rescanning. We do not have gating capabilities yet in proton radiotherapy, but we have been doing extensive research, and I think we're probably going to launch it in the very near future. And then lastly, this is just, with photon-based liver SBRT, just because that's what 99% of our patients are getting treated with. There is daily pre-treatment co-beam CT. I know exactly where I'm targeting every single day. We don't have CT on rails yet. For our proton radiation right now, we are still currently relying for the most part on KV imaging, so this is what I'm treating to. I definitely need fiducials for the liver, and we're looking at bony anatomy. And so this is where, if I'm treating up against the heart, if I'm treating up against critical structures, I start sort of mentally praying that my patient's getting randomized to photons versus protons. And then additional challenges, as I alluded to in the US, insurance challenge coverage can be huge. Just healthcare expenditure in general is a huge concern. And this can really impact the randomized controlled trial enrollment. And we have to think about that when we're looking at the results from our randomized data. The patients that are really covered are Medicare population, which is our older population, so 65 and older that are covered, not the 50-year-old who has private insurance. That private insurance is not going to cover clinical trial enrollment. So we have to think about that. And then just in general, as we talked about healthcare expenditures at large, the cost effectiveness of proton beam, I think we need to really prove it. It's behoven to us to prove that there's a true benefit. So as I conclude, this is just a state of the union. For HCC, I think there really is strong rationale for proton radiation randomized controlled trial underway. I think for the esophagus, there's really an intriguing impact on the immune system, and there's certainly convincing evidence of decreasing postoperative complications. And there's ongoing studies evaluating TCR oligoclonality, and we do have that randomized trial. And then I think for anal cancer, it's feasible. I think it's on a case-by-case basis, but the future is probably less certain. So thank you very much for the invitation and for your attention. I'll take any questions.
I'm from Taichung Veteran General Hospital, and I want to ask, many patients with HCC, they will receive embolization therapy first. So is there evidence showing that we can add on maybe photon or proton therapy to increase their local control? And if we add on radiotherapy, do we have to adjust the total dose of the radiotherapy?
So that's a really good question, is, with these local therapies, more and more, and we see them in this multidisciplinary tumor board where I meet patients with IR all the time. And we know that oftentimes we're going into that liver toolbox over the course of their, disease course many, many times. And it really is by the end of their treatment, the disease course, they've probably seen many, many modalities. And how do we combine all of these is a really good question. I would say traditionally for embolization, pure embolization, I don't really factor that at all into my equation. More complicated now is this, the rise of Y90 or radioembolization that I think is increasing. I don't know how frequently Y90 is done here in Taiwan. It's gained a lot of attraction, I think, mostly due to a lot of companies that have pushed it forward. The combination of Y90 and radiation is much more complicated. There are some prospective studies looking at how to adequately combine it, because I don't even think that Y90 in and itself, the IR folks have really great dosimetric quality assurance of how that dose is getting deposited. There's a certain dose that they say is getting deposited, but there's massively hot spots and cold spots that exist in that. There have been, I've looked into a lot of this literature of how to combine it, a lot of retrospective data. And once again, Y90 is very complicated. Is it a lobar? Is it a segmental? Is it a subsegmental? All of that impacts, probably tolerability. I think earlier on, there was concern for higher RILD associated with the combination of the two. Michael Buckstein did a really nice Red Journal article not too long ago looking at TACE followed by SBRT and comparing it to Y90 versus SBRT and not showing a difference in terms of toxicity. So I think that it is doable. I actually do routinely do consider it. I think it's a tough question of should we be thinking about protons versus photons in that population that's already seen some Y90. I think it also depends on where the prior Y90 was. Is it in your treatment field, or was it separate, a separate lesion that was on like the contralateral side of the liver? But I think it's a really good question that I think a lot of literature is going to be focusing on the near future with Y90 on the table.
Thank you for your great talk. You had mentioned the comparison about proton and the photon therapy for liver cancer. It's equal in local control, but overall survival is proton therapy is maybe better. And the explain is about the decompensation. Would you please explain more about this?
Yeah, so the idea of the liver decompensation is that it's really driven by, we know that underlying liver dysfunction is critical in terms of predicting of, if it's a child's Pu A versus a child's Pu B, C. I mean, C we don't touch in the United States, and certainly at our institution. If you look at rates of decompensation, traditionally it's about maybe 10% or less for child's Pu A, but it can be upwards of, a third or higher with child's Pu B patients, and I would say B6 versus B7 is a significant, or B7 versus B8 is a significant difference in and of itself. So I think that the exact status of the liver is critical. So, most of the literature that exists out there really look at sparing of uninvolved liver, and there's lots of different sort of metrics that have been published on how to optimize dose and what is the right dosimetric planning parameter to use. But that was just one, when they looked at remnant volume of liver getting 10 gray or less, that was one of the first studies that established that as a potential factor into it. But I think it all sort of goes to the same point that any uninvolved liver is critical to spare as much as possible, especially among patients that are at higher risk. So, child's Pu B, definitely. I think those are the ones you have to be concerned about.
Thanks so much. For HCC, if the tumor is very close to the GI tract, would you prefer to do X-ray or proton? Because X-ray has high dose conformity, but the proton can spare the low dose exposure. What's your opinion about that?
Yeah, so good question. I would say for, if it's up close, like if it's a segment 2-3 of the liver and it's up against the stomach, and that makes me really, first thing I'll do is do 15 fractions, because there are 5 fraction schemas and there's 15 fraction schemas. The 15 just allows for more daily, it's a lower dose per day. It just mitigates a little bit more flexibility in terms of like day-to-day variability of where that stomach is. I will generally really mandate that patients not, have as much as I can empty stomach for 2 to 3 hours leading into it. I generally prefer photons because I can appreciate on a cone beam CT and make sure that stomach is out of the field versus proton where I'm using purely fiducials in the KV imaging where I really have no idea where that stomach is. But once again, I think the one gastric perf I've ever had, which was pretty significant in a patient who has, liver decompensation, was on a transplant list, was 5 fractions with protons. And so I'm always a little bit skittish about that if I don't know 100% sure where my stomach is.
I'm just curious, when your patients were enrolled in a randomized trial, do you have to offer free proton therapy like the drug company did?
Well, the first thing we do, a good question. The first thing we do is we actually check that the insurance covers protons. If it does not cover protons, although it's very cleverly written, but if it's 5 fractions, it actually can count towards SBRT. There's a lot of insurance sort of, but it's not free. It has to be covered by the insurance. But we do have we can get coverage either through proton radiotherapy as a modality or SBRT. SBRT is 5 fractions or less in the United States. And SBRT with oligometastatic and just an awareness of ablation, it tends to be covered more frequently. But it definitely is a challenge, as I mentioned, for clinical trial enrollment. If they are not covered, we do not offer it for free. Yeah. Okay. Thank you very much for all the questions.